better or not? Thank you.
Thank you. It's again a pleasure to be back in Turkey, and as I keep saying, I don't know, I can't even remember the counts how many times I've been to Turkey in various meetings. Um, this is actually all the people who are sitting here, majority of them know all about this. I think there might be some trainees who may benefit from this because majority of the stuff that I'm dealing, some of them is coming from Professor Fessler who's sitting there, some from Urban, there are some papers from there. So all this is about why you should use MIS. It's been, again, Mehmet, a pleasure, and Jumar, really both of you have done great work to get this together, and so many people this time is fun, although I think some of them disappeared just now while we were having lunch. Um, Pakistan, as you all know, is one of the most fascinating countries regarding what we have up in northern mountains, and this is a range which has some of the highest mountains in the world. Well, we know about these milestones that Mixter and Bard explain the traumatic or degenerative origin of disc with the lumbigo and causing a sciatica. And actually, MIS kind of thing, or thinking about some kind of fusion, was more than 30 years ago when Walter Kluger and McGrill designed and used the pedicle screws. Well, Foley and Smith came up with their tube retractor way back in 1997. And the whole concept of surgery in spine is that we need to access a surgical target deep inside into the body. There is a surgical path. An approach is created to that path. The target is approached, surgery is performed, and we close the path. Despite following normal anatomical paths, surgeons destroy normal and functional tissues, leaving scar tissue behind, which is functionally inactive and potentially causing a problem with pain. So there are footprints which are left behind. So basic principle of surgery is to effectively treat pathology with minimal disturbance of normal anatomy, leaving the smallest footprint. So minimally invasive surgery is approaching a target via keyhole and trying to have significantly less effect behind. So do we have evidence of all this, that if there is a muscle injury during retraction, does that cause problem? There have been papers coming way back from 1998, 1996, 89, 71. So all these papers have been there, which tell us the histological, immunohistochemical, enzymatic, electrophysiological, and electrical clinical evidence of muscle injury. So if you see an MRI 18 months post-op microdiscectomy, you can see the problems that we're seeing. So we know open surgery is associated with morbidity. There is more post-operative pain. There's longer hospital stay. Cosmetically, it's displeasing. And there are scars, and those scars can give rise to problems later on as well. So what's the difference? It's only the excess. The decompression has to be identical. So the goal has to be achieved in both surgeries. So larger retractors, when you use larger retractors, they typically translate into longer stays. So, pain could be caused because the patient is staying longer, require more narcotics, in bed longer, muscle relaxants are used. And all this obviously can lead to multiple complications. So MIS, why did we have to think about it? Because we thought we could give less collateral tissue damage, measurable degree of decrease in morbidity, faster recovery, and the idea is that if you cause less pain and smaller incisions, you can have faster recovery, and you achieving the intended surgical goals as a conventional surgery. So is muscular retraction really that important? So, way back, this study from 1999 showed spine surgery causes damage to surrounding muscle. Injury can be followed by atrophy of the muscle. And among the different surgical approaches, it appears that what's incision in the midline and separation through big retractors causes more problems than anything else. So what's the mechanism of muscular injury? It's direct injury by dissection, stripping off from the attachments, and extensive use of cautery, localized thermal injury and necrosis to the tissue. And most significant factor responsible is likely to be the force that we apply with our self-retaining retractors. And you see one of your assistants, putting all their force and trying to see a little bit extra and going all the way out because you need to dissect all the way down to the transverse process. So what impact of muscle retraction was shown in 1998 in rats and back muscles. What they had was 2 hours of continuous retraction, 5 minutes retraction, and release for an hour, then again retraction, and 5 minutes release at every 40 minutes. So 3 groups, and they showed that in all these groups, histochemical studies at 48 hours, 1 week, and 6 weeks, serum CPK measurement at 48 hours, muscle degeneration maximum in group 1, CPK highest in group 1, regenerated muscle fiber of smallest diameter in group 1. So showing that there is significant problem there. Taylor then published in 2002, looking at the impact of self-retaining retractors on paraspinal muscles, 20 patients, and they measured the pressure, and muscle biopsies were taken before and after retraction. You're looking at the ATP. And they showed there was significant increase in IMP during retraction, reduction, function reduced, function following retraction. There was reduced ATP in their patients. So denervation is yet another mechanism that lead to muscle degeneration and atrophy following surgery. Long retraction time obviously correlates with high signal intensity that we see 6 months post-op. Clinically, can we correlate that? Yes, there appears to be a correlation between muscle damage and long-term post-operative pain. Signs of severe degeneration of multifidus in patients with failed back syndrome have been shown in many studies. Muscle biopsies showed signs of advanced chronic denervation consisting of group atrophy, marked fibrosis, and fatty infiltration. So preservation of function and integrity, can we do that? If you do MIS surgery, less crushing surgery, less direct compression, less local ischemia, no denervation. So in these, the extension strength correlates with preservation of multifidus muscle. So this is shown again and again. Stevens and colleagues assessed the post-surgical appearance of multifidus using a high-definition MR, and they showed exactly the same thing what we just talked about. So effects are not only local. There's decrease in tissue trauma have local effects, but can also have systemic effects. So markers of skeletal injury, aldolase, CPK, cytokines, interleukin 10 and 1 are 7-fold up on open surgery versus MIS group. The greatest difference between the groups occurred on the first post-operative day. Persistently elevated levels of pro-inflammatory cytokines have been associated with organ failures in some of these patients. So this is a paper myself and Yoakum wrote a few years ago talking about can full endoscopic interlaminar disc surgery, a gold standard yet. And we talked about how if you go through using a tubular retractor versus cutting the muscles, the difference between the two was quite obvious. So open laminectomy, marked increase in flexion, extension, and axial rotation. When you have increased movement, you're more likely to have problems associated with it. So if you have less scar, less post-operative pain, quick recovery, shorter hospital stay, lower complication, less blood loss, less soft tissue damage, and smaller incision. Has that all been shown yet? Let's have a look. Lateral stenosis, interlaminar endoscopic versus micromacroscopic. The results were all the same. The only advantage theoretically was said that there was reduced trauma in these patients, talking about more cosmetic results and claiming that on MRI we had better results. So I'm not going to go into details of that. MIS principles, we need to remember that, again, we do whatever we do, but we have to be certain that we perform the surgery that we have come to perform. Prospective studies, it's a comparison of one level, posterior lumbar interbody fusion with a minimally invasive approach to a traditional open approach. So they had 32 cases in this initial phase. And what they showed was that overall, the pain was much less compared to traditional open group throughout in this 12 months period. And then this, again, study, a prospective study from 2009, and 29 MIS TLIF, 29 open TLIF, 24 months follow-up, and basically showing that hospitalization, VAS, ambulation, morphine requirement, all that was much better in MIS. The problem that we had was fluoroscopy time. That was significant, and that needs to come down, and people need to understand, and that gets better with learning curve, clearly. So blood loss, infection, all that was much better with MIS. So complications rate differ, and they differ. With open, you get increased incidence of surgical site infections, UTIs, with MIS, higher number of transient neurological deficits, unintended urotomies, and hardware complications. But all this was in the initial phase of the surgeries. All this with MIS was seen. Now we are seeing less and less of that as more and more people get to learn and understand the risk and the problems associated with it. So this study by Kevin Foley looking at MIS versus open, similar radiographic fusion rates, early postoperative pain and disability outcome, postoperative time, whereas with MI, TLF, lower blood loss, lower complications, shorter hospital stay, higher fluoroscopy time, significantly better improvement in the LACE-VAS-BAC scores. So what about the adjacent segment degeneration? It remains a significant long-term consequences following spinal fusion. So MIS techniques to lumbar fusion avoid the extensive tissue dissection, and we are hoping that in longer term, we're going to have less of adjacent segment disease following this. And there are some studies which have already shown that. So if you look at surgical site infection, there's decrease in incidence of postoperative infection shown by many authors, and reducing hospital stay, reducing infection rate, obviously reduces the cost incurred with it. This is an MIS TLIF versus minimally invasive and open, and they looked at, especially looking at when they had the results in reduced operative blood loss, hospital stay, 2-year cost, and accelerated return to work. So economy was a big problem. So surgical morbidity, hospital readmission, and short and long-term clinical effectiveness were similar with both these procedures, although it said that it may represent a valuable and cost-saving advancement. So there is no class 1 data to support MIS TLIF, PLIF over open technique for lumbar degenerative disease. There is class 2 and 3 demonstrating improved short-term outcomes with MIS, less blood loss, less need for pain medication, quicker mobilization, reduced infection, equal long-term results at the moment. So in conclusion, MIS obviously can decrease iatrogenic injury, accelerate rehabilitation, reduce hospitalization, continued development of minimally invasive techniques will definitely lead to us doing near procedures and having better results with lesser complications. Thank you.
Thank you so much, Dr. Sharif. Just now, I have a comment about that on the base of your experience, how much level that we can the percutaneous fusion?
How much?
Levels of the lumbar. 1 level or 2 level, we can do percutaneous or not?
Percutaneous fusion?
Yes,
Or
instrumentation.
As many number now, with the newer systems, you can do many levels.
For example, that the many systems allows only 1 level or 2 level. On the base of your experience, that which kind of the system you are you using, and how can we can do that?
Okay, what I'm using is basically can go up to 2 levels, and basically for me that is I don't do more than 2-level TLIFs as required. And if at all, if I need anything more than that, then I'd be thinking more in line of putting a tubular retractor above and below and decompressing that particular route. But if I need to fuse, then I'd go with open at that stage.
Yes. Regarding the percutaneous instrumentation and fusion, I think the very main problems is the fusion. For example, that after the instrumentation, that in your presentations at the first that the performing the TLIF and others, just at the same incision and the same incision you are doing the TLIF?
Yeah, same.
Or, yes.
So basically it's extension from one screw to the other. So
yes.
That's the extension, and you work through the same Wilsey's plane.
And the small incision?
Yep.
Yes. And in these situations, do you think the effective the cartilage and to create a good the cavity to create a good fusion may be weak or not, fail or not?
I think when you're starting out, it is definitely difficult, and many times you think you're not able to compress that much or distract that much or not able to decompress as much as you want to decompress. But I think we know that if you've done about 40 of these MIS TLIFs and you're up to 90% to where a master should be. If you have done about 12 of these, then you are able to do 50% of these things comfortably. But when you have done beyond 40, I think it becomes much easier and easier.
Thank you so much. Any others and comments?